Faiza, can you still see the screen?
Yes, I can.
Okay, good. All right, what do you think, Jenna? You're on mute.
I think I'm good to share my screen. I just need to get the presentation up.
Okay.
So just give me 1 sec
No.
to do that.
Demonstrating how to put on a splint. We're demonstrating how to conduct a damage assessment or to do a lift or a carry.
Sorry, just need 1 more minute and we're good to go.
I think we're all accustomed to everyone's trying to learn all the ins and outs of these virtual presentations.
Okay,
Okay, I'll stop sharing mine.
okay, I just need to pull it up. Okay, and then, okay, I will start sharing mine. So are people seeing what we're doing right now? Hopefully not.
Yes, they are.
Oh,
There's a-
okay, how's that? And then let's just,
right.
good?
Yep.
Okay.
Great. All right. So are you ready to go then?
Yes.
Yep.
All right. Well, thank you, everyone. I appreciate the courtesy that you've shown us as we kind of work through some of these technical issues. But anyway, I appreciate you all being with us here this morning or this afternoon, depending on where you're located. Hello. Anyway, this is the first of 4 virtual ICDP symposium presentations. My name's Barb Clark, and I am the Training and Exercise Manager for the Intermountain Center for Disaster Preparedness, located here in Salt Lake City, Utah. As we're embarking on this brave new world, we hope that you will find some comfort in hearing how others have dealt with various disasters and tragedies and come out on the other side stronger and more resilient. I was going to say this later in my intro, but if you could all please mute your mics for us, that way we're not having interrupting conversations happening. Although we know that the networking opportunities here on this Zoom platform are not the same as our in-person presentations, if there is someone that you are looking to connect with following the presentation, just let me know and I'll see what I can do to help you connect with those folks. Following this and the 2020 symposium, or all of the 2020 symposium presentations, you'll be receiving a SurveyMonkey evaluation. If you could take a few minutes and fill that out, it really helps us to develop a stronger symposium for our future presentations, which hopefully by next fall will be back to in person. Also, if you need a certificate of presentation for any of the presentations, including this one, please email me and I will send you one. As a matter of housekeeping, as I said before, just follow the common virtual meeting courtesies by making sure that your mic is on mute. You can choose to keep your video on and off, on or off, whichever you prefer. If you have questions, we will be monitoring the chat area, so please submit your questions via that portal. At the end of the presentation, we'll open up to additional questions, at which time you're welcome to unmute yourself and ask them verbally or continue to ask them in the chat center. Again, thank you so much for your continued support of the Intermountain Center for Disaster Preparedness. And if we can be of any service to you or your organization, please feel free to reach out. We're here to help you in any way that we can. All right, without any other further ado, I'd like to introduce you to our presenters today. Since 2017, Faiza Haq has been with the Greater New York Hospital Association, which is a trade association that represents more than 160 member hospitals and healthcare systems in the New York, New Jersey, Connecticut, and Rhode Island areas. Ms. Haq currently serves as the Senior Project Manager for the New York Reducing Avoidable Hospitalizations Project, which is part of the CMS Nursing Facility Initiative. Ms. Haq also functions as the Fatality Management Lead for the Greater New York Hospital Association, acting as the liaison between New York City hospitals and numerous other city agencies. Prior to these roles, Ms. Haq has worked in various hospital settings, including emergency departments and intensive care units. Ms. Haq earned her Master's of Health Administration from Columbia University's Mailman School of Public Health and her BS from the University of Maryland, Baltimore County. Our other presenter today is Ms. Jenna Mandel-Ricci. She serves as the Vice President, Regulatory and Professional Affairs at the Greater New York Hospital Association. Jenna supports member hospitals in two principal areas: emergency preparedness and development and implementation of internal employee wellness programs. Her emergency preparedness portfolio includes assisting members to develop and continuously strengthen planning related to mass casualty response, patient surge, and readiness for infectious disease outbreaks. Under her leadership, the Hospital Association has led many initiatives to improve coordination between hospital and government response agencies. Jenna has supported members through a number of emergency events, including Ebola, Zika, measles, power outages, severe weather, and most recently, the COVID-19 patient surge, in which she served as the Greater New York Hospital Association Incident Commander. Before joining the Hospital Association, Jenna spent the previous decade in various positions with the New York Health Department and positions at the New York City Department of Health and Mental Hygiene. Her last position was as Executive Director of the Bureau of Healthcare Systems Response Readiness within the Office of Emergency Preparedness and Response. Jenna is the proud mother of two and holds a Master's in Public Health from Hunter College, City University of New York, and Master's in Public Administration from the School of International and Public Affairs at Columbia University. Please join me as we welcome Jenna and Faiza, who will discuss the events and share lessons learned from New York City's unprecedented COVID patient surge and mass fatality that overwhelmed the area's entire death care system. Jenna and Faiza, it's all you.
Good morning, everyone. Thank you, Barb, for that introduction, and thank you to the Intermountain Center for Disaster Preparedness for inviting us to speak today. We're very honored to be here and be a part of this event and share our recent experience with all of you. Barb shared a little bit about the Greater New York Hospital Association and a little bit about Faiza and myself, but I just wanted to share a tiny bit more information. As Barb mentioned, Faiza and I both work at the Greater New York Hospital Association, which works to meet the needs of its hospital members on a diversity of topics that you can see here. Emergency preparedness has been a core competency of the association since Y2K preparations, if you remember those, back in 1999. We're a large trade association, as Barb said, with members across New York, New Jersey, Connecticut, and Rhode Island. And notably, all New York City hospitals are part of our membership. And given this fact, we play a particularly critical role in the emergency preparedness and response landscape in New York City, serving as a bridge between the city's 55 hospitals and the many city, state, and federal agencies with which they must interact. And you already heard quite a bit about Faiza and myself and what our roles were during the recent COVID patient surge and frankly, the resurgence that is happening now. So I think I'll just keep us moving. So now to the topic of interest, how New York City's hospitals and the broader community managed the fatalities that came hand in hand with our spring patient surge. We have done our best to lay out the presentation in a methodical way, though the event itself was anything but. We will first share a bit about the New York City context and what fatality management plans existed pre-COVID, and then discuss the city's overall fatality surge before moving into the hospital experience. We will conclude with how we are preparing for future waves and future emergencies. It's important to note that any event resulting in mass fatalities requires a whole hospital and whole community response. We have tried to make this aspect apparent in our presentation today, and we know that there are attendees with many different roles in the audience. Given the complexity and criticality of fatality management, we believe there is something for everyone to take away. At the end, we very much look forward to your questions, observations, and suggestions. I'm now going to turn the floor to my colleague Faiza to discuss the New York City context and pre-COVID plans.
Thanks, Jenna, and good afternoon, everyone, or good morning, depending on where you are. I'd like to join Jenna in expressing our appreciation for being invited to participate in this event today and sharing our experience with you all. To start, I wanted to provide an overview of the New York City landscape, along with some details about the fatality management preparations that Jenna mentioned were in place prior to the initial COVID-19 patient surge, which really hit New York City in mid-March. So to start off with the broad picture of the New York City landscape, New York City has approximately 8.3 million residents, making it the most populous city in the US. And in regard to the hospital picture, there are 55 hospitals in New York City across the 5 boroughs, those being Manhattan, Brooklyn, Queens, the Bronx, and Staten Island. Of those 55, 15 hospitals are independent, while the remaining 40 are part of larger health systems such as New York Presbyterian and Mount Sinai. And in terms of fatalities, there are approximately 100 to 150 fatalities seen per day across New York City. And this includes deaths seen in hospitals, in nursing homes, residential at-home deaths, and more. And in a few moments, we'll compare this number to what we saw during the patient surge. But before I move on, I just want to emphasize that while we at the Greater New York Hospital Association have members throughout New York and neighboring states, during this presentation, we'll really be focusing exclusively on the New York City mass fatality management response. New York City, as you all know, was the epicenter of fatalities back between March and May. And that required very quick action, distinct protocols, and well-defined operations between the hospitals, the partners, agency partners, us, and other departments. However, as Jenna and I think about how to improve fatality management operations in the future, one of our organizational goals is to speak with the surrounding counties and areas to see how the resources that we created during the initial patient surge can benefit all of our surrounding members, and we've made some progress in this field already. So on the next slide, I'd just like to provide some context on the various organizations and agencies that were involved during the COVID-19 fatality management response. First, we have the New York City Office of Chief Medical Examiner, or OCME. And on a typical day, the New York City OCME manages, of course, the medical examiner cases and also any unclaimed cases or those that have no next of kin identified. Additionally, OCME released a biologic incident surge plan back in 2018 and a hospital toolkit in more recent years, both of which have helped hospitals create a mass fatality management plan. And we'll talk in a little bit about how that served as the foundation for the fatality management response during this specific emergency. Next, we have the New York City Office of Emergency Management, which supported OCME in various aspects, one of them being a lot of logistical concerns around the response and different contracting needs that were needed. Next, we have the New York City Department of Health and Mental Hygiene, specifically the Bureau of Vital Statistics, which and they played a crucial role typically they play a crucial role in ensuring all births and deaths are registered, and that death certificate component was a large challenge during this emergency, which I'll touch on in a little bit. And I just want to point out that New York City is unique in that the city DOH registers death certificates rather than the state. And then lastly, we have the Greater New York Hospital Association, which of course Jenna and Barb both mentioned serves as a liaison between our hospital members and various response partners and agencies. So on the next slide, just want to point out that OCME did take the lead in ensuring all hospitals had a fatality management in place prior to this emergency. New York City, unfortunately, is no stranger to mass fatality events. An initial plan was created in 2008 with major updates made in 2016 when OCME released a hospital toolkit. And all hospitals were required to have a mass fatality management plan in place. Most of these were most recently updated in 2018 as part of a citywide hospital preparedness program, or HPP deliverable. And an important note is that OCME's guidance and hospital plans were based on the assumption that hospitals would only need one BCP, or body collection point, on site at any given time. And for those of you who are unfamiliar, these BCPs, or refrigerated trailers, serve as extensions of morgues for hospitals when there is a high volume of fatalities and hospitals have to hold on to a high volume of decedents at one time. And then I'll discuss in a little bit, again, why this assumption of holding only one BCP was such a significant factor in this COVID-19 response in New York City. And with that background, I now want to jump into the fatality surge seen in New York City. And, this is a very sensitive and morbid topic, but I think it's really important to share our story and for, all of us to improve the fatality management responses in any given emergency. So on the next slide, I'll start by providing you with some important numbers, which again highlight the enormous toll experienced by the entire death care system across New York City. So at the height of the surge between March 11th to May 31st, there were 38,000 deaths seen across New York City. Again, this includes hospital, residential, and nursing home fatalities. And at the peak, the city was seeing approximately 1,000 deaths per day. And again, I just want to compare that to the number that I had mentioned before, where New York City on average sees 100 to 150 deaths per day. So this was 10 times that amount. And of course, naturally, this put an immense amount of stress on the entire death care system across New York City. This includes hospitals who are managing decedents and reaching out to their respective families, to the New York City Office of Chief Medical Examiner, who typically doesn't have the resources to manage this high volume, and even to funeral home cemeteries and crematoriums who didn't have the ability to surge to the capacity that was needed, and they have restrictions on the maximum number of burials and cremations that can occur per day. And all of this added to the backlog in the system. And I'll touch on various regulatory flexibilities that were made down the road, which did help alleviate some of these challenges, but unfortunately did not, erase the problems. And it's important to remember that all of this is happening while the city and nation are on lockdown. Hospitals are experiencing extreme levels of patient surge that they haven't seen before, on top of, addressing this overwhelming fatality surge. So on the next slide, I want to talk about disaster portable morgue units, or DPMUs. So to accommodate for this unprecedented volume of fatalities, OCME, or the Office of Chief Medical Examiner, established 4 DPMUs across the city. DPMUs 1 to 3 did previously exist in the city's surge plan and were activated for this emergency and used to manage mostly residential deaths. DPMU 4 was a newly established site, which was located in Brooklyn and is still running today. And it's used exclusively to manage in-hospital deaths and to hold those body collection points that I mentioned earlier. And I just want to emphasize those body collection points, or refrigerated trailers, are large 53-foot trucks that hospitals had to hold on site in different areas alongside their facilities. And I also want to note that DPMU4 did later become the site of the long-term freezer storage facility, which you may have heard was created in New York City as a solution to various challenges that I've mentioned and we'll go into more detail about. On the next slide here, and before I turn it back to Jenna, I want to provide some detail. Oh, sorry, before I provide some hospital-specific experiences, we wanted to share this clip with you all, which is part of a Time article and does a really nice job of explaining the tragedy and challenges experienced with New York City and the severe impact that it had on families. So Jenna, if you wouldn't mind playing the video, and then we'll stop it at 2 minutes and 30 seconds because it's quite lengthy, 8 minutes long, but after we do encourage you all to view the entire thing if you have the time.
Faiza, I'm not sure it's working. So let's see.
Okay.
Can I go to this one and then we can just stop it? What do you think about
Sure.
that?
That sounds
that
good.
Works. We're just rolling with the punches here, folks. Sorry. Here we go. This one, right?
And Jenna, you'll have to switch your screen share to the browser.
Sorry for the ad, everyone. Hold on.
So Jenna, you'll have to stop sharing, click on your screen that you want to play, and then start sharing again.
Oh, I have to stop share, I see.
Right.
Okay. Hold on one sec. I'm sorry. Hold on one sec, everyone. I'm sorry. This is not.
You know, we're all learning this new platform.
I think we're just going to skip it. How does that sound?
Okay. Do you want me to try, Jenna, or?
Sure, that'd be great.
Okay.
Let me see if I can. I can't seem to get it to stop either. Apologies.
That's okay. We'll just do one more attempt, and if it doesn't work, we'll move on.
Just trying to find it to turn it off.
How's that, Barb? Do you see that?
We are seeing that now.
Great. Let's see if the sound works.
And there is no sound. Oh, something happened there.
To go up highest.
Okay, we have sound and video.
752 with the past day.
Maybe we don't have sound anymore.
Single increase in the number of deaths. 752 with the past day. See each day above 700 at devastating level.
I've been a medical examiner here in New York City for 22 years. Our job generally is to support families. 9/11 was to support families by providing identification. In this pandemic, our job is to increase our capacity so that we have a place to care for decedents, for loved ones, with respect and dignity until families are able to make their final. Family may not be able to afford a funeral right now because they lost their job, or they're themselves ill, or there's just a capacity issue with the funeral director. We have alleviated that additional burden at the worst time of their lives so that they can have their loved one put to rest in the manner that they wish.
It was a very complicated, very difficult response to COVID. We put reefer trucks early on at every hospital, over 130 trucks out at the 55 medical facilities.
All right, I'm just going to stop it there. Like I mentioned, it's quite a lengthy video. It is, you know, a really trying time for the families, and the video does a nice job of explaining the city's response to managing not only the decedents, but also, you know, the families. So at this point, I'll turn it back to Jenna.
Thanks for bearing with us, everyone. Just getting our slides set here. Let me get back to where we were. Is everyone seeing the slides?
Yes.
Yes, great. Okay. Great. So now that Faiza has provided you with a broader fatality context in New York City, I want to turn to the experience of New York City's hospitals. Let's begin with an abbreviated timeline. While we now know that COVID had been circulating much earlier, the first confirmed cases occurred the first 2 days of March. By March 7th, New York State began waiving regulations, allowing hospitals to operate differently with an eye toward surge capacity. The week of March 16th, Governor Cuomo ordered all hospitals to increase bed capacity by 50 to 100%. And the following week, hospitals were ordered to suspend elective surgery, though most had already curtailed these services on their own. During the same week, March 16th to 23rd, the New York State Department of Health began daily data collection that enabled us to count hospitalizations. And in a single week, 7 days, they went from 103 COVID hospitalizations to 2,213. And for the next 3 weeks, the onslaught continued, peaking at 12,000 hospitalizations on April 12th. By early May, the situation had begun to stabilize and hospitals began to focus on reopening. This slide shows our New York City hospitalization trend. It is difficult to describe how swift and overwhelming the surge in hospitalizations was between mid-March and mid-April. This was a completely unknown pathogen. PPE shortages plagued the region and the nation, and patients were arriving very, very sick with few treatment options. The EMS system was also completely overwhelmed. New York City's 911 system is the busiest in the world, with about 4,000 calls per day on average. On a really busy day, calls may hit 4,500. During COVID, the system was receiving 6,500 calls per day, with a significant portion of the workforce out sick. As these patients poured into emergency departments, hospital resources were understandably focused on caring for the patients that were there and trying to stay ahead of the surge by rapidly creating more beds in every nook and cranny in and around the hospital. A major lesson learned that we will touch on throughout today's presentation is that patient surge and fatality surge preparations must go hand in hand. And here is what in-hospital fatalities looked like in New York City from mid-March to late May. The difference in color bars is due to using two different data sources to create this graph. At the peak, about half of the fatalities were happening in hospitals, with the other half in the community, as Faiza talked about earlier. While usually fatalities are a lagging indicator, so many patients were so sick upon arrival that patient surge and fatality surge were happening simultaneously. I recall what an emergency manager at a small Queens hospital shared with me. Her 200-bed hospital with no full-time work staff pre-COVID was at the epicenter of the outbreak. She described how patient after patient would arrive at the hospital very sick but stable, decompensate quickly, and die within a few hours of arrival. During the worst of the surge, this would happen multiple times a day. This chart shows cumulative in-hospital fatalities. And as Faiza will detail in a moment, for some time, there was no back door. Hospitals were confronted with managing increasing numbers of decedents. With the entire death care ecosystem overwhelmed, hospitals were left to manage a host of complex and interconnected issues. I'm now going to turn things back to Faiza to discuss the cascading impacts of this situation in detail.
Thanks, Jenna. So on the next few slides, I'm going to take some time to describe what we call cascading impacts, which summarize a lot of the compounding factors that cause significant challenges within fatality management across the city. And after, I'll provide some solutions created to address these said challenges. So to start, there were substantial issues in regard to mortuary space and staffing. Typically, our hospital's fixed internal morgues hold anywhere from 5 to 10 decedents, with our safety net hospitals being on the lower end of that range. Based on the numbers shared earlier, there were times hospitals were seeing, 30 to 40 fatalities per day, and they couldn't keep up with this volume. And this in turn led to a domino effect in terms of backlog, as filled morgues resulted in decedents occupying inpatient beds for an extended period of time, resulting in ED delays and more. And there was also an increased amount of mortuary techs that were needed to handle the high volume, but obtaining more staff in this field proved difficult. And I recall there's one hospital who typically has one mortuary tech on staff any given day, and they had to increase to 12 during this emergency, which was not an easy feat. And I'll share a little bit more about that hospital story in just a few moments. And then when we got to a point where the city deployed the body collection points or refrigerated trailers, this came with its own set of challenges. So as I mentioned earlier, hospitals plan to hold one BCP on site at any given time within their previous fatality management plans. However, many of our hospitals were found holding 3, some even 5 at one time. And the logistics and security that had to be taken into account when managing all of these were quite challenging. And to increase volume, as seen in the time video that we shared earlier, OCME required all hospitals to add shelving to their deployed trailers to increase the capacity within them to double, triple capacity because they weren't at a point yet where they could actually retrieve those trailers from the hospitals. This unfortunately had its own unintended consequences for hospitals who already had decedents within the trailer. So of course it's it's difficult to erect, construction within them. Furthermore, managing the decedents within the trailers required additional monitoring, appropriate storage, and of course proper handling to provide respectful care to loved ones. And most importantly, in regard to decedent management was the issue of long-term holding. So hospitals and the city, frankly, did not plan for decedents to be held within the trailers or the hospital at all for more than a few weeks, maybe 2 to 3 weeks. However, some decedents were held for as high as 50 days. And the BCP, while it provides refrigerated storage, it cannot allow for indefinite storing of decedents, and a solution was needed swiftly. And lastly, communication with families, as you can imagine, was very challenging. A lot of that was touched upon in the time video. And this was partly due to the visitor prohibition, where families were unable to come to accompany their loved ones in the hospital, partly due to funeral directors who typically do a brunt of that outreach when someone passes, and partly due to misinformation being disseminated across the city. And one piece of this misinformation was this fear around temporary burials for families who couldn't make arrangements within a timely manner. That did not occur, but prior to the long-term storage option being set up, which I'll discuss, families were concerned that their loved ones would, in fact, be temporarily buried. And of course, that's unfathomable to even imagine. And of course, our hospitals had the family's best interests at heart and were hesitant to send decedents to OCME if they didn't have to. And so they tried to hold on to them for as long as they could. And as Barbara Sampson, the chief medical examiner, states in the video we shared, families cannot handle this uncertainty, and they just needed the facts. And the severity of this incident didn't allow for normal closure for their loved ones. Moving on the next slide, I've already mentioned a bit about the backlog in the funeral home industry, which resulted in delays in final dispositions, final arrangements for decedents. And unfortunately, no one had anticipated the severity of these delays and how they would place even more pressure on the hospitals. Additionally, there was also ever-changing guidance throughout the height of the patient surge, to no one's fault, but just the nature of the beast. And this involved how OCME retrieved decedents, and typically they only retrieve the medical examiner or the unclaimed cases, which I mentioned are those with no next of kin, but this had to be changed based on how long hospitals were holding on to decedents. And a lot of these process changes affected the documentation and paperwork required for each decedent, which is quite lengthy, and there's numerous items involved in that. So for those hospitals seeing 30, 40, 50 fatalities per day, they, naturally had a difficult time keeping up with this. And one piece of information that was particularly tricky were death certificates. And typically, funeral directors play a really critical role in completing death certificates, but as I mentioned, they were too overwhelmed and hospitals had to manage and take on this responsibility as well. And finally, there were broad PPE and supply shortages throughout New York and across the country. And specifically in the city, one of the shortages was with body bags or human remains pouches. And at one point, the ME office asked that all decedents be stored in disaster or more durable body bags, which are even more difficult to obtain. And the point of these disaster bags is they can allow for extended storage and more movement. And in terms of movement, I remember speaking with a hospital who found that after a patient expires, there are anywhere from 5 to 10 decedent movement or handling actions that occur. So this could include transfer from a bed to the morgue, transfer to and from a refrigerated trailer, BCP, transfer into a body bag, and more. And to avoid any injury, disaster bags were encouraged to handle the amount of movement that was occurring. So that was a broad array of challenges. And before I get into some of the solutions that were implemented, I want to walk through a quick timeline to outline some events. So as Jenna mentioned, the first case of COVID-19 or confirmed case of COVID-19 occurred in early March. And the first official COVID-19 fatality in New York City occurred in mid-March. And fatalities increased at an exponential rate, as Jenna shared on the graphs earlier. And this required the first body collection points to be deployed to hospitals on March 21st. Prior to this date, all hospitals were managing any decedents they had within their fixed morgues. And as I mentioned, those could only handle 5 to 15 decedents. So many of these decedents, hospitals had to be creative and store their decedents in other areas. Then on March 25th, OCME began holding daily fatality management calls with hospitals and key stakeholders and began requiring hospitals to report their decedent census on a daily basis. And we're continuing to collect the census data even today to closely monitor census counts and have that increased visibility across the city. Both of these things, the calls and the collecting the census in the event of a future wave would start earlier or the census would just continue because we have not stopped that. It's been really helpful to monitor that data and see any spikes. And then at the end of March, OCME asked all hospitals to add shelving into their refrigerated trailers to increase capacities. And at the end of March is also when the federal DMORT or Disaster Mortuary Operational Response Teams arrived in the city. And the DMORT teams were really crucial in creating the DPMU-4 site that I mentioned earlier for the hospital deaths and holding those BCPs. Then in early April, hospitals were asked to increase their mortuary staff by 3 to 4 times to accommodate for the volume. And initially, hospitals were asked to recruit through their normal internal recruiting process, but this proved to be very difficult because of the nature of the job. And of course, the shortage in general. And also by early April, all hospitals did have by then at least 1 BCP on site with a total of 83 deployed across the city. So some had more than 1. And then the peak of COVID-19 related fatalities was seen on April 7th. On April 14th, DPMU-4 became operational, and on April 17th, the maximum number of BCPs were deployed across the city for a total of 135. So after talking through that timeline on the next slide, I just want to illustrate how all of those factors impacted a particular hospital. The hospital we've identified here is located in the Bronx, and it's one of our safety net hospitals. And the Bronx is one of the poorest congressional districts in the country. Both the Bronx and Queens in New York City saw the highest number of fatalities in this emergency. And you can see here what that daily toll looked like for this particular hospital. Their peak in fatalities was seen in early April with over 30 fatalities a day. and their fixed morgue only held 15 decedents. So you can imagine the toll that this took on them if they're seeing 30 per day. And at the height, this facility had to manage 4 BCPs on site, each again with its own logistical and security issues. And in terms of staffing, this is the hospital that I mentioned that went from 1 mortuary tech and had to increase to 12 to manage their census. And you know, that management includes management of the BCPs, movement of the decedents, outreach to families, ensuring all paperwork is there, communicating with the ME office and others. So it's quite, it took quite a toll on this hospital and others. So this just tells the story of one hospital who had limited resources, but had to, you know, innovate and find ways to manage the high volume. So on the next slide, I just want to address, you know, what the city addressed the challenges that we're seeing, and we had to find a way to dig ourselves out of this hole and start making changes in real time. And hospitals and agencies had to work together to create these innovative solutions. So in terms of mortuary space and staffing, the city utilized the Medical Reserve Corps, or MRC, to recruit volunteers that were willing to work in morgues, and they were able to match approximately 115 volunteers to a variety of hospitals. Greater New York also reached out to a handful of funeral director and veterinary associations with the hope that their members would be comfortable working in morgues just based on their experience with working with the deceased and grieving families. So we had to be creative a little bit. For BCP management, the New York City Office of Emergency Management and others provided logistical support. So as I mentioned, the ME office did require shelving in the units to increase capacity. So the Office of Emergency Management assisted with this, and they pre-installed shelving to BCPs prior to deploying them to hospitals. And while this was a very welcome resource at the time, unfortunately, it resulted in some unintended consequences when it came to the actual retrieval of the trailers. So decedents, it was found, couldn't be secured properly within the shelved BCPs. And so this was a major lesson learned during the first wave, as we saw a lot of challenges when it came to decedent and BCP retrieval. And then with regard to decedent management, it's important to note that it's not normal protocol for the ME office to retrieve claimed cases or those that have family working with funeral directors to make final arrangements. So typically the ME office just takes custody of any cases and unclaimed cases. But in this emergency, the ME office did have to adjust their processes to retrieve claim cases due to the extended period of time that hospitals were holding on to decedents, as I mentioned, you know, for over a month at times. This extended hold at the hospitals also led to the creation of a long-term freezer storage option, which is still operational in New York City today. And I'd love Jenna for Jenna to jump in here and kind of just walk through a little bit about how that long-term freezer storage option came to life.
Faiza, thanks so much. I asked to jump in here because I have a very clear recollection of an early April interagency call. It was apparent that we had no good options. We were keeping decedents in these body collection points for far too long, as Faiza mentioned, 50 days and even longer, and there were growing concerns about decomposition. And many families were simply unable to make arrangements in the immediate term, either because they lived out of the country, they didn't have the money, or many other reasons. And we needed to buy families time and simultaneously manage the decedents in a respectful way. So we began to brainstorm any and all options, and one of our OCME colleagues mentioned that Chicago had created a long-term storage option, basically a giant freezer where decedents could be stored indefinitely. Everyone on the call agreed that a similar operation for New York City could be a real game changer. And to the credit of our agency colleagues, within a few weeks, they made this a reality. Back to you, Faiza.
Thanks, Jenna. So even with that long-term option, hospitals still needed support with decedent management, both in regard to paperwork and physical labor. And this led to the creation of something called strike teams. So these teams brought together military support, the New York Police Department, and other agencies to provide a heavy influx of resources to one hospital at a specific time. And this came at the perfect time when OCME did alter their processes that they could pick up those claimed cases that did have family involvement, but there was delays in final disposition. And then lastly, hospitals had to be creative with managing families and reaching out to families, allowing virtual viewings when applicable through using technology as best they could, and using various city resources to field calls from families such as the Unified Victim Identification System in New York City, or UVIS. So on the next slide, I'm going to go back to the backlog seen in the funeral home industry. So Governor Cuomo in New York did sign an executive order which allowed for out-of-state funeral directors to practice in New York State to provide that additional support that the funeral homes needed based on their backlog. There were also some helpful changes made in the paperwork arena. So to our ME office's credit, they did want hospitals, they wanted to help hospitals reduce the paperwork requirements to just what was truly needed at the time of retrieval. So they only required the absolutely essential information when they did get to the point of retrieval, and found other means to obtain the additional items or just retrieve that information from the hospital at a later date. Lastly, Greater New York also worked with our Department of Health to add body bags to the weekly PPE and supply deliveries as best they could. Next, I want to continue with the timeline, but this time focusing on the changes and solutions that were made to address the challenges initially discussed. So on April 18th, OCME made the decision that they could retrieve claimed cases, and began with this retrieval on April 28th. When the long-term freezer storage option became operational at DPMU 4. Very soon after, by May 5th, OCME had retrieved over 1,000 decedents and 18 BCPs from New York City hospitals. And in total, those strike teams that I mentioned were able to retrieve over 2,000 decedents. So they were then disbanded on May 21st, when only 39 BCPs remained deployed across the city. And over time, in the beginning, the hospitals, it took quite some time for them to complete the strike team visits. There was a lot involved in it, but over time, hospitals became more and more prepared. So the visits lasted in the beginning approximately 10 hours, but then later were reduced to 3. So by that point, the strike teams were able to complete multiple visits per day. So the retrieval process became faster. And then all BCPs were returned to the staging location in New York by June 22nd. So as you can see, even with all these resources that we've discussed, it did take quite some time to catch up and get to a good stage in the city. And while the patient surge, as Jenna mentioned, was under 4,000 by mid-May, the BCP retrieval process wasn't completed until late June. So there were great innovations made, but in the event of a future wave, we do hope that they come sooner so that this timeline is shortened. And with all these innovations and lessons learned, things finally did start to improve, and we turned our attention to preparing for future waves and emergencies that could result in this high volume of fatalities. So I will turn it back to Jenna now to discuss some of those next steps.
Faiza, thank you so much. So as Faiza mentioned, in July, as we collectively caught our breath and took stock of what happened, we knew that there were a host of improvements that could be made in the near term to increase the preparedness of the hospital community. A major lesson learned was the importance of frequent interagency communication. And to that end, we are now meeting regularly with agency partners, including New York City Emergency Management and the Office of the Chief Medical Examiner, to advance planning goals, develop resources, and review data. And just to reflect on that, as we've started to see over the last month or so, our cases start to creep up again. This is just really underscoring the importance of this fantastic interagency communication. GNYHA is now sharing on a daily basis an ED or Emergency Department Syndromic Surveillance Report and a daily morgue census report with all New York City hospitals. New York City Emergency Management is working to ensure the logistical support is available. Of the BCPs used during the initial surge, 120 are being maintained for use during a future surge. And understanding the importance of staffing to patient and fatality surge, New York City Emergency Management has established a citywide group purchasing organization staffing contract that hospitals can elect to use. And mortuary operations staff is one of the many roles that are included in that contract. We also know that our member hospitals are working very hard to modify and improve their internal plans. To support their efforts, a number of resources have been created. The medical examiner has taken great pains to update the existing hospital toolkit, including detailed operational information specific to COVID. We as an organization created a comprehensive lessons learned document and a special considerations document that outlines several planning areas of particular challenge along with suggested solutions. And all of these documents and more are available on a dedicated fatality management document portal and resource hub that GNYHA is maintaining on its website. And back in August, we hosted a virtual symposium to share these resources and information with our members. Lastly, we have worked with the City Health Department to provide additional carrots for hospital fatality management planning. As the holder of the ASPR Healthcare Preparedness Program contract for New York City, the Health Department has deliverable-based contracts with all New York City hospitals, and there is always what we call a design your own deliverable option. So together with the Health Department, we outlined the suggested deliverable that you see here, and it nicely illustrates the interconnectedness of many of these efforts. So for example, hospitals are urged to define new roles and create corresponding job action sheets within their plans and consider ways to increase their internal morgue capacity. Some facilities have added space to their existing morgue through renovations, whereas others have identified and retrofitted areas such as labs or endoscopy suites that could be used as surge morgue spaces. And all hospitals are strongly urged to detail how they will maintain multiple BCPs on site if that becomes necessary in the future. So that is our story until the next chapter is written. And at this point, we thank you so much for your attention and we welcome your questions and observations. And Barb, I think I'm going to stop sharing my screen. And I think you have been monitoring the chat and we'd be happy to take any questions or share any more information.
All right. So one of the questions was, in the media, we saw that there were a lot of questions on how they defined a COVID death. So if someone came into the hospital, they had an MI, and then they died, and then they were later discovered to have COVID, were those counted in the COVID numbers?
So I can try and answer this one, and I must confess that I am not an expert on this by any means, but this definitely was a point of interest, frankly, among the public health and the healthcare community, as well as the media. I do think it's important to remember that in the beginning, we were flying blind. We had very little testing. And frankly, we still don't have enough testing. So what I can say with certainty is that at the height of the patient surge, except for very emergent cases like people having STEMIs or strokes or heart attacks, all of our hospitals were filled with COVID. So there was a presumption and so many people, because of what was going on, were delaying care or avoiding going to the hospital. So the presumption was that if you were dying in the hospital and there wasn't another obvious reason, it was from COVID. I do know there was testing going on, and obviously doing testing of fatalities was a priority. And I do believe that our public health department, our Department of Health and Mental Hygiene, has been doing a lot of retroactive testing and corrections to the numbers. So I think that is still in question. And it's also frankly possible that there were deaths before March 1st or 2nd that happened that were COVID, and we just didn't recognize that it had already been circulating within the city and within the country, frankly. So I'm going to leave that one to the public health experts to handle, but that's what I know. Faiza, I don't know if you have any other information you'd like to share.
No, I have nothing else. Thanks.
Great, thank you. And then I actually had a question. One of the statements you made was that there were restrictions on burials and cremations, that there were only so many allowed per day. Why is that?
So I can start. I think at cemeteries and crematoriums, I think it's crematoriums in particular, just based on the instruments and what they utilize. There's a limited number of cremations that they can complete per day. They allot a certain amount of time, and just based on those regulations that existed pre-COVID, that also contributed to the backlog. They were at capacity and completing as many as they could, but that still didn't meet the demand, unfortunately, that we saw.
Okay, so it wasn't like an environmental, like you can only get so many parts per billion in the atmosphere or something like that for cremations, or?
I don't believe so.
And just to add to that, I think for the cemeteries, the burials, it was really the rate limiting step was staffing. They were pulling in the same way everyone else within the death care industry and the healthcare industry was pulling in surge staffing. The cemeteries were pulling in as many people as they could, but they were just limited by, and the funeral directors as well. I mean, we've all heard stories about how funeral directors were doing the equivalent of a month or 2 months worth of funerals in a single week. So they just literally couldn't keep up with the demand.
Thank you. So here's a question from Gregory. He says, what mistakes do you see other states making now that you wish you help correct? What mistakes do you see other states making?
Greg, I think I get the gist of your question. I don't know that I think what was unique about what happened in New York was just that you saw that curve that we went from 100 COVID cases to 2,200 in the course of a week. And we had so many people dying so quickly. I think the mistake that we made was not being adequately prepared and understanding that fatalities were going to go hand in hand with the patient surge. And frankly, I don't think anyone could have foreseen what happened. I think just overall, and you see this in the papers and on the news now, staffing is the rate limiting step in healthcare across the board, right? If you don't have the staff to take care of the patients, and I think there was such an understandable focus on taking care of the living that's where all of the staffing effort was, and it wasn't. We were constantly playing catch up on the mortuary operations and fatality management operations. And I think it took quite a while for hospital operations to recognize that there needed to be a huge staffing effort as well as an operational effort to manage the fatalities. So if there were any advice that we could give, it would be to have as part of your patient surge plan, a really well-developed fatality surge plan as well. And Faiza, you were really living and breathing it. So I'd love for you to jump in with your thoughts.
Yeah, of course. And what I'll add is, I think what we learned is that this fatality management, a lot of the operations that were needed to manage these fatalities required not just emergency managers and morgue managers and morgue techs, but also folks from other staff from other departments. Admitting had to be involved, as they were very, they were needed to handle a lot of the paperwork requirements. We needed leadership to really own this and stress the importance of managing these morgues and following through with different guidelines. And we needed all of these parties involved in any communication that occurred with the NE office and the Office of Emergency Management, and just streamlining that documentation so that it's so that all parties involved have that guidance was really crucial. And so that's one of our major lessons learned. And we're trying to create fatality management teams in each New York City hospital. And it involves, like I mentioned, the emergency managers and morgue managers, but also security and facility staff who were crucial in the management of the body collection points. Some of the trailers needed ramps or security tenting around it or privacy screening. So there's more that goes into it. And so we're trying to create that interdisciplinary team And so we would, encourage other folks to do the same.
And if I can add one more comment that I just thought of, and I think this became clear in the video, which I know is a little hard to follow. One thing that I don't think I sort of really recognized in the fog of war, so to speak, was the fact that everything we were seeing in the hospitals was only half of the story of what our colleagues at the New York City Medical Examiner were dealing with. They had just as many deaths that they were managing residentially, and the collection and management of those deaths was even more complex. So we were advocating as much as we could for the attention that our hospitals needed, but now looking at it with some perspective, just thinking about what they were frankly up against. And these were seasoned professionals that dealt with 9/11 and our leaders. And you heard Frank DiPaolo on that video talk about how overwhelming this was. So I think if anything, it's really coming to the table with your medical examiner colleagues or coroner colleagues, however it works in your jurisdiction, the police department, emergency management, and really talking about how this would work from a whole community perspective is so important, because how we treat our dead says so much about us. So.
Great, thank you. Are there any other questions? Let's see. Can you see that question, Jenna?
We can. I think that would be a great one. Faiza, I don't know if you're reading it. It's a question about staff burnout, and I think you'd be great to start talking about that one, and then I can jump in. Oh, you're on mute, Faiza.
I'll read it out loud. How did you handle the rate of staff burnout amongst those who were involved in this aspect of the response? We are currently experiencing a significant spike in COVID-19 cases here, and after being in this response since March, our staff are already burned out and now dealing with more cases than ever. Yeah, and I think that's a really great and important question. That's been one of the things that Greater New York and a lot of us are focusing on, because we do understand the toll that this takes on staff. So one of the things we did is we provided some mental health resources for our staff. We, especially those who work in the morgues, they were seeing something that they hadn't seen before. Any volunteers, they weren't used to this kind of work. So we tried to, as best we could, link them to some resources, encourage, folks to reach out and reach out to speak with someone, or have or gain that mental health help that they needed, just to, they were in these hospitals surrounded by COVID day in and day out, and they needed some sort of outlet. And Jenna, do you have anything to add there?
Sure. This is as Barb mentioned in the beginning, I cover two areas: emergency preparedness and employee well-being. So this is like right in my wheelhouse, this question. We have been spending a lot of time and effort thinking about the well-being of our staff, and very much in response to what Malia said, understand, and we're seeing this. I mean, I'm starting to hear from some of our frontline providers who are seeing their first COVID cases trickle in again. And it's that horrible feeling you get, like, oh my God, we're in this again. I will say one of the most interesting things that came out of this is, you all may recall that because New York City was sort of the first to deal with this, we had a lot of military resources that came to New York City that helped staff the USNS Comfort and the Javits, and the DoD has been an amazing partner, and they do a lot of work around traumatic stress. And they really, at the end of our patient surge, said to much of our leadership, this was like a war. This was like a war zone, and we have resources that we think could be helpful. And so we actually, with them, adapted a whole curriculum that had been designed for helping the enlisted to manage traumatic stress, and it's called Hero New York, and we're making it available to everyone. And Barb, I can follow up with you with the website resources. And through that, we actually have gotten to know some folks that head up the center, and I'll put this in the chat, the Center for the Study of Traumatic Stress. And they have put together some really interesting resources, particularly for mortuary operations staff, and particularly talking about how do you talk about grief and how that's really the role of leadership. And that in addition to providing all kinds of resources for your staff, you have to talk about grief and you have to collectively grieve. And we have seen, and I'm sure you all are doing the same things, we unfortunately lost quite a few healthcare workers. And it's horrible enough to see patients die, but to see your coworkers die is devastating. And I know many of our health systems have put a lot of thought and effort into memorial services for their coworkers who have passed. And that's been a moment of coming together and healing that's been really, really important. And I think just sort of being able to have kind of rituals of mourning for the patients that people have lost. And of course, and I'm sure your hospitals are doing this. I mean, I've seen so many videos of every time someone with COVID leaves the hospital and is discharged, they have like a song, like one hospital had Here Comes the Sun, that they would play over the PA system, like really celebrating the victories, because especially in the beginning in New York, there just honestly weren't that many victories. And so we definitely have some resources that we have put together. And I will say, sorry to be going on so long about this, but I feel really passionate about this area. So many of our hospitals and health systems that already had well-being and employee wellness programs very smartly pivoted those to do that sort of acute help. And they were doing things like rounding on the units. And another group that you can't forget about is we had so much of our workforce that went remote like that. And those folks are sort of adrift. And so a lot of our health systems have done some really interesting work where they're supporting the remote workforce and really thinking about their particular needs as well. So much of the attention has been on the frontline providers, as frankly it should be, but thinking about your entire workforce and how they're all being impacted by this. So we definitely can put together some resources that I can share with Barb to put out to folks.
That's great. Thank you. That was Scott's question about sharing of resources. So I will go ahead and send everyone the link to the video, as well as some of the resources that Jenna shares with us. And looks like Malia says, thanks for sharing. Sorry that you had to all go through this. We're using this to learn, but we appreciate you and what you guys do. So thank you all.
Well, thank you for letting us join you. And our contact information is on that last slide, and please do contact us with questions. We all are learning from each other during this. So
thank you all so much.
Okay, great. Well, thank you, everyone. Appreciate everyone participating. Thank you, Faiza and Jenna. It was very, very informative and very useful information. And I just want to thank my my coworker, Dr. Karen Blackwood. She helped get everybody admitted and monitored the chat. She is the director of the Intermountain Center for Disaster Preparedness. So thank you, Karen, as well, for helping out today. Everyone, hopefully we'll see you back here next Wednesday when we'll be talking about an active shooter event at Mercy Hospital in Chicago. So thank you all, and thank you, ladies. Really appreciate you presenting here today.
take care. Bye-bye, everyone.
Bye.